All right, let's jump straight into this rapid-fire surgical MCQ explainer. We're going high yield today, so let's get right to the first vignette. Picture a 44-year-old guy. He's got this heavy feeling in his left leg that gets way worse when he's standing for a long time, but it actually feels a bit better when he props it up. On exam, you see a 4 by 5 centimeter ulcer right over the left medial malleolus. Look at your options here. Arterial, venous, syphilitic, traumatic, or neuropathic. Based on that presentation, we're definitely looking at option B, a venous ulcer. Let's unpack the why behind this. This is classic chronic venous insufficiency. Basically, you've got hydrostatic back pressure literally forcing red blood cells right out into the dermis. Macrophages come in, break them down, and leave behind iron. That's exactly what creates those brown hemosiderin patches you see in the gator area. It's like a rusty stain left behind on the skin. Left unchecked, the tissue gets this woody induration, right? We call that lipodermatosclerosis. The key takeaway here is, assuming the ankle brachial index is totally normal, your first-line therapy is multi-layer graduated compression. Think of an UNABOOT to counter that pressure.
Okay, moving right along. Which of the following surgical complications is most associated with polycythemia vera? We've got wound infection, venous thromboembolism, muscle spasms, or delayed recovery. Because of the extreme prothrombotic state baked right into this disease, the answer jumps out at us. It's option B, venous thromboembolism.
You know, the driver here, it's that activating JAK2 V617F mutation in the bone marrow. It causes a massive expansion of red blood cell mass, skyrocketing the hematocrit. This creates a severe hyperviscosity state. It's like trying to pump sludge through microvessels. It just physically slows everything down. Add hyperreactive platelets to the mix, and you're setting the stage for some really nasty atypical clots, like Budd-Chiari syndrome. Clinically, you'll also hear these patients complain of aquagenic pruritus. It's this crazy intense itching right after a warm shower, thanks to mast cell hyperplasia. And remember, before they even hit the OR, you've got to aggressively phlebotomize them to get that hematocrit safely under 45%.
Let's look at another ulcer case. A 33-year-old heavy smoker comes in with severe rest pain in his toes. Oddly enough, hanging his legs off the side of the bed actually provides gravity-assisted perfusion and helps the pain. The ulcer itself has punched-out margins and really poor granulation tissue. Between venous, arterial, syphilitic, trophic, and tuberculous, this specific cluster of symptoms strictly points to option B, an arterial ulcer. So what's happening physiologically? This tissue is literally starved of oxygen. Given his young age and smoking history, we're probably dealing with thromboangiitis obliterans, or Berger's disease, driving severe peripheral arterial disease. These ulcers love to sit distally, right on the digit tips. You'll spot dependent rubor when the leg hangs down, and sudden elevation pallor when it's raised, plus completely absent distal pulses. And listen, this is a massive pearl. Because the arterial supply is already critically low, wrapping this leg in any kind of compression therapy is an absolute contraindication. You could literally cost the patient their limb. The only goal here is urgent revascularization.
Next scenario. You're in the ICU. An intubated patient on CIMV suddenly crashes. Hypotensive, tachycardic, tachypneic. What is your absolute best next step? Call the anesthetist and wait, needle decompression, rush to the operating theater, perform section and get ABGs, or disconnect and manually ventilate. When faced with this sudden catastrophic hemodynamic collapse, you literally only have one viable life-saving move. It's option B, immediate needle decompression. This is a classic tension pneumothorax. That positive pressure from the ventilator, it's been pumping air through a lung injury straight into the pleural space, acting exactly like a one-way valve. The trapped air builds up rapidly, violently shifting the mediastinum and just completely crushing the vena cava. That instantly cuts off venous return to the heart. You'll see the clinical triad: tracheal deviation, ipsilateral hyperresonance, and jugular venous distension. You have to act fast. Grab a 14 to 16 gauge needle and decompress at the second intercostal space along the mid-clavicular line. Do not, I repeat, do not wait for an X-ray. Waiting for imaging here is a fatal error. Let's shift gears over to vascular surgery. A 72-year-old man is 24 hours post-op from an aorto-bifemoral graft, where the inferior mesenteric artery was ligated. He suddenly develops abdominal distension, a fever, and bloody diarrhea. Which diagnostic study do you order? Aortogram, MRI, CT scan, sigmoidoscopy, or Iberium enema? The right call here is option D, sigmoidoscopy. Here's the mechanism. When you ligate the IMA, you're rolling the dice on the patient's collateral blood flow through the marginal artery of Drummond. If that collateral flow turns out to be inadequate, you inadvertently starve the embryonic hindgut. That fever and bloody diarrhea, that's acute ischemic colitis screaming at you.
Doing a bedside flexible sigmoidoscopy lets you safely look directly at the rectosigmoid mucosa to spot those cyanotic patches and sloughing. And a huge warning here. Option E, the barium enema, is completely contraindicated. Pumping pressurized barium into an ischemic, fragile bowel is basically begging for a catastrophic perforation and fecal peritonitis.
All right, here's a stable, young patient who comes in with spontaneous, right-sided chest pain and some mild dyspnea. The x-ray shows a small 1.5 centimeter pneumothorax. You've given him some O2. What's the next best step? Thoracotomy, chest intubation, thoracocentesis, increase the O2, or discharge with outpatient follow-up. For a small, stable pneumo like this, the correct protocol is actually E, discharge with OPD follow-up.
This is what we call a primary spontaneous pneumothorax. Usually it's caused by the rupture of subpleural apical blebs. We see this a lot in tall, thin, young guys. The British Thoracic Society guidelines are really clear on this. If the pneumo is under 2 centimeters at the hilum and the patient is minimally symptomatic, you do not need an invasive intercostal drain. Plus, putting them on high-flow supplemental oxygen in the ED is a neat trick. It changes the nitrogen gradient between the pleural space and the capillaries, which actually quadruples the rate that the trapped air gets reabsorbed. So they're completely safe to go home and follow up as an outpatient.
Let's talk cardiopulmonary bypass. Which of the following is not a complication of a CPB procedure? Vascular injury, infection, cholelithiasis, air embolism, or pulmonary injury? The odd one out here is pretty obvious once you think about it. It's option C, cholelithiasis.
Think about what actually happens during bypass. You're exposing the patient's entire circulating blood volume to synthetic tubing. That triggers an immediate, massive systemic inflammatory response syndrome, or SIRS. It fires up complement and coagulation cascades, leading to nasty, acute issues like microembolization, coagulopathies, and ARDs, what surgeons often refer to as pump lung. But cholelithiasis, gallstones, that's a super slow, completely separate metabolic process driven by cholesterol supersaturation. It has absolutely zero to do with the acute, violent mechanics of a bypass machine.
Staying with the heart, what is a definitive indication for coronary artery bypass grafting? Is it a 30% left main stem stenosis, a 40% proximal LAD stenosis, 3 main coronary arteries diseased, a single main artery diseased, or poor ventricular function with multivessel disease? The absolute classic indication here is option C, 3 main coronary arteries diseased.
When we talk about triple vessel disease, meaning significant blockages in the LAD, the right coronary artery, and the circumflex, surgical bypass provides a clear, definitive survival advantage over just doing a percutaneous intervention. CABG is also heavily indicated if there's critical stenosis in the left main coronary artery, over 50%, or if you have multivessel disease combined with a severely tanked ejection fraction, under 35%. And remember, the workhorse of this surgery is the left internal mammary artery, or LIMA. Surgeons love routing the LIMA to bypass the LAD because its long-term patency rates completely blow standard vein grafts out of the water.
Okay, next vignette. A 40-year-old patient has a massive, recurrent, malignant pleural effusion secondary to lung adenocarcinoma. How are we managing this locally? Chest intubation with sclerotherapy, thoracocentesis with sclerotherapy, pneumonectomy, chemotherapy, or doing nothing. For optimal long-term volume control, you want option A, chest intubation combined with sclerotherapy, also known as pleurodesis.
Here's the logic. A malignant effusion is just going to keep coming back, constantly compressing the lung and causing brutal dyspnea. You have to drain the fluid completely with a chest tube, and then you infuse a highly irritating sclerosing agent. Sterile talc slurry is the classic choice. That talc kicks off a dense, sterile, inflammatory response that literally glues the visceral and parietal pleura together. If you obliterate that potential space, the fluid simply has nowhere to accumulate. The only catch? The lung has to be able to fully re-expand and touch the chest wall for that fusion to actually happen.
All right, a quick technical question. What is the appropriate operating table position for a left-sided video-assisted thoracoscopic surgery, or VATS? Right lateral decubitus, left lateral decubitus with tilt, Trendelenburg, or reverse Trendelenburg? The exact setup you need is option C, the left lateral decubitus position with a tilt.
Patient positioning is everything in VATS. You secure them in lateral decubitus, sure, but articulating or breaking the table right under the tip of the scapula is the secret sauce. That mechanical flexion physically bows the patient's body, which splays the intercostal ribs wide open. It gives you maximum interspace room to get your instruments in while avoiding painful crush injuries to the intercostal nerves.
You pair that wide-open access with dual-lumen single-lung ventilation, and boom, you've got a beautifully unobstructed surgical field. Back to the oncology ward now. A patient's been admitted with a massive pleural effusion hanging around for a month. You put in a drain, and the fluid cytology comes back positive for adenocarcinoma. What's your immediate next step? Chemotherapy, pleurodesis with a sclerosing agent, radiotherapy, pleurectomy, or nothing. The immediate palliative move here is option B, pleurodesis with a sclerosing agent.
Malignant effusions are textbook exudates. They easily satisfy Light's criteria, meaning you'll see a pleural to serum protein ratio greater than 0.5 and an LDH ratio over 0.6. But clinically, you have to prioritize. Before this patient ever sees an oncologist for systemic chemotherapy, you have to fix their breathing. Chemical pleurodesis provides rapid, durable, local palliation. You restore their respiratory mechanics and improve their quality of life first, so they're actually stable enough to tolerate systemic treatments down the line.
Last question to wrap this up, focusing on regional anesthesia. What is the most common complication of an intercostal nerve block? Pneumothorax, hemothorax, nerve damage, bleeding, or fistula? The most frequently encountered procedural complication here is option A, a pneumothorax. It all comes down to the anatomy. You remember VAN, right? Vein artery nerve. That neurovascular bundle tracks strictly along the inferior or lower border of each rib, tucked safely inside the subcostal groove. So to hit the nerve without striking the vessels, you basically have to walk the needle right off that lower edge. But the margin of error is incredibly thin. Just a single millimeter of accidental deep advancement, and you've punctured the delicate visceral pleura. So the next time you're visualizing this anatomy, ask yourself, just how precise is your spatial awareness, knowing that a fraction of a millimeter is literally the only thing separating perfect pain relief from a collapsed lung.